Okay. Hi, everyone. Thank you for being here and welcome to the Centre for Social Impact's seminar series for this month. I'd like to begin by acknowledging that today at the Centre for Social Impact UWA, we're meeting on the lands of the Whadjuk people of the Noongar Nation, and I'd like to pay my respects to the elders past and present of this land, as well as any First Nations people in the room. Today we are very lucky to be hearing from Dr. James Herbert, who is actually a member of the Centre for Social Impact staff. He joined us last year as a senior research fellow. He is very experienced at researching and talking on the topic that we're going to cover today. So James's background, he looks at research on the interaction of criminal justice, child protection, and the mental health systems in responding to children affected by abuse. And he actually looks at how the system wraps around this issue and what successful collaboration across sectors can look like. So it's very important work. The topic is preventing and responding to child abuse and neglect, a review of best practice system approaches. So while we're talking mainly about the systems around child abuse and neglect, we also acknowledge that this is a very difficult topic to think about and to research in. And so, but it's very, very important to talk about so that the issue can be addressed. So I applaud you, James, for diving into this topic and presenting some best practice insights today. And thank you to everyone else for taking an interest. Take care of yourself during the discussion. After we hear from James, we will have about 20 minutes between 12:40 and 1, where we can bring questions and comments into the room and talk about it with the expert here today. So, James, I will hand over to you to present.
Terrific. I'll just get my slides up. All right, can you see my slides? We all good, Lizette?
Perfect, James, go.
Cool, awesome. Everyone, thanks so much for your time today. I normally present primarily within, I guess, my own topic and area. So yeah, I quite enjoyed the challenge of, I guess, taking my topic, multi-agency responses to abuse, which probably seems kind of niche, and I guess thinking about how to explain it to a general audience, how to, I guess, frame it within the entire context of the child protection system and the broader discussions about child protection responses. As Lizette said, just a little content warning. That said, I'm a policy researcher and program researcher, so my focus is really more on how systems respond, but just a heads up that we are talking about abuse and sexual assault. So do feel free to tune out if you're feeling distressed, but there's not anything particularly graphic or specific in the presentation. So I am James Herbert. I've been with the CSI for about 6 months over here at UWA. Prior to that, for about 10 years, I was at the Australian Centre for Child Protection at UniSA, and yeah, had the chance to work on a wide range of child protection research and evaluation projects nationally. But the focus of my research over the past 10 years has really been about the multiple systems and agencies involved in a response to abuse, um, with a particular focus on child sexual abuse. Part of the reason for the awkward title here is that we don't really have a good word for this sort of system response in Australia at a national level, besides calling it a system response. In the United States and Canada, you might call it a child or youth advocacy centre. In Europe, it's Barnahus, which is Icelandic for children's house. Essentially, what I'm referring to here is the range of government and non-government agencies that have a really important role to play in responding to abuse, and the arrangements that exist to help them all work collaboratively to keep children safe, support access to justice, address the harms of abuse, all while minimising the distress and uncertainty for children and families. So it is a little bit of an unorthodox talk, as rather than presenting a study, I more want to send out the big picture of multi-agency responses in the first section, sort of what we learned from the whole series of studies that we completed as part of my postdoc and through various evaluation and research topics. And in the second section, really make the case for the importance of therapeutic services and family support as absolutely critical elements for multi-agency responses to abuse, and conclude with a bit of a call to action on therapy access. So I'm going to be covering a lot of ground, so very happy to return to anything that's of interest in the following discussion. And again, if you don't have access to any of these articles or journal articles or anything, please get in contact. Very happy to send them on, very happy to help people connect with the research. Otherwise, very happy to discuss anything in the presentation, and would love for this to be the beginning of some interesting discussions and connections that lead to doing some good stuff. Okay, my slide is very slow. There we go. So I wanted to start by quickly talking a bit about my research approach and I guess why I do the work that I do. Social programs are incredibly important as potential drivers of change, but I worry that too often social programs and interventions are not taken as seriously as, say, programs in health and medicine in terms of how they're funded, delivered, and evaluated. According to on Accordingly, on a range of social problems, we've not made much progress, and in some cases, things have gotten much worse. In getting to how we might do better and the role that research might have in contributing to that, there's really three papers that have been really important in building my research worldview. So this is going to sound incredibly nerdy talking about my favorite researchers and papers. So one of my favorite papers, Segal et al. So they demonstrated that the best predictor of obtaining improved outcomes was that there were activities in the programs that are specific, make sense, and that they're being delivered to the intended target group. Now, this sounds like a really low bar, but in their review, they looked at 53 published home visiting programs that were intending to prevent child abuse and neglect, and found that only 7 of 53 met this criteria, and all 7 of them demonstrated an improvement on outcomes. Conversely, all the programs that did not have a clear match between its program theory and its target group did not improve outcomes, and programs with a partial match had partial improvement. So what you really take from this is just the importance of the match between program theory, the underlying assumptions and explanation of how a program makes change, and the match to the target group, that the assumptions of the program match the population it's being delivered to. So hugely important point. Secondly, without high quality implementation support and processes for monitoring whether a program is being delivered as intended, we can't really draw meaningful conclusions about if a program has worked. So if we don't have processes to ensure the program's being delivered as intended, there's every chance that it's not being delivered as intended. So Fixon, in this paper, he gives the example of an initiative to fund evidence-based programs, the stuff you love, big multi-million-dollar program to roll out the stuff that we know works. Their review really identified that less than 10% of programs delivered in this initiative were delivered in line with the program specifications. So people were saying they were doing circular security, incredible years, all these evidence-based programs, but their review process really identified that when you matched it against, I guess, the core content of these programs, less than 10% of them were being delivered in line with the specifications. So this paper really presents countless reviews in different fields that show that the quality of implementation of a program is just as important as the type of program or the contents of the program and the likelihood of improved outcomes. So that was a really important piece of understanding for me, just about fidelity to, I guess, the core principles of what a program is supposed to be. Finally, uh, for just about every program, there's a wealth of knowledge out there on, I guess, components of programs that work, but too infrequently is there consideration of whether a program has been successfully implemented somewhere and whether it had the effect the provider hoped. So Pawson's realist synthesis approach That's really all about the fact that social programs have really common elements. And if we can just understand the effect that these components of programs have in particular contexts and with particular target groups, we can design new programs with these elements and have a high degree of assurance that it's likely to work. So what I take from these three big points is we need a more rigorous approach to understanding and addressing social problems, clear approaches founded in evidence with a clear explanation for how it works and for whom, that recognizes the value of evidence, lived experience, and the experience of knowledge of the people delivering the programs. And of course, acknowledging the unique experience and cultural knowledge of Aboriginal people about addressing the intergenerational effects of colonialisation. Summing up, I do the work that I do because I want the world to make sense. I want progress on social problems. I want governments and the community to have confidence in the investments made to address these problems, for the sector to not have to rely on guilt or political sensitivity as the basis of funding. And I want practitioners to be able to apply their skills in a framework they can have confidence in. And most importantly, I want clients to have confidence in the quality of the program that they're putting their time and effort into. Hopefully none of that's too controversial. Turning to our subject matter, to not labour the point, child abuse is extremely common and extremely harmful. So the recent Australian Child Maltreatment study has provided the first proper prevalence data in Australia. And not only is abuse much more common than previously thought, we now understand that for most kids, abuse is multi-type and chronic. Abuse exacts a huge cost on the community and individuals. The ACMS has also put large scale Australian data to demonstrate the direct impacts in terms of increased mental health symptomatology and increased health risk behaviour. Now, numbers at a certain point lose their meaning, but I think the general gist of the economic impacts is that exposure to abuse and neglect is possibly one of the largest drivers of health and social inequality there is. And something I've been thinking about quite a bit recently is long-term follow-ups really suggest that around half the people that have experienced child sexual abuse will experience sexual assault again at a subsequent life stage. So this suggests that we're currently not doing well in terms of addressing the factors that put people at risk of re-victimisation. So when we think of child abuse, probably we're primarily thinking about our state territory statutory agencies. Almost everywhere, child protection systems are overwhelmed with the volume of reports that they need to investigate and respond to. And there's continuing growth in reporting, partly as there are a wider range of things we understand to be harmful to children, such as exposure to family domestic violence. So our systems are based on some quite outdated assumptions about abuse and neglect, namely that abuse is rare and hard to detect. So the system we have, the forensic legal system, is really built around receiving reports, triaging them, and undertaking investigations to determine whether the threshold is met for a statutory response. And despite the volume of repeated reporting and really concerning risks that exist in the community, only a small proportion of reports actually get a child protection investigation. Outside of that investigation, the system primarily relies on referral and voluntary engagement of families to often under-resourced treatment and prevention services. And these are services that are usually built for early intervention, but are often working with families right at the cusp and beyond of statutory intervention. There is, of course, a lot more that could be said about the functioning of the child protection system, but there's a broad recognition that we need to move from a residual system that really only works with ones that match a certain threshold to one that works much more broadly and operates under a public health approach. So this looks like a system that works beyond the direct child protection system, includes approaches to address the drivers of abuse and neglect, invests in effective prevention programming at a larger scale than just that tertiary system, and includes a range of responses rather than just the statutory system and the process of removals. At and in particular, given the degree of overrepresentation includes high quality Aboriginal led family support and healing services. So these, of course, are things that are already being done to different degrees by state and territory governments, but the bulk of resources and attention all still sit at the tertiary system, and in particular in out of home care, with the primary and secondary systems being funded really as quite a patchwork of different programs and services with limited connection to the reporting system. So it really calls for quite a massive culture shift in order to set up the scale and quality of the primary and secondary systems that we need to make real change. All, of course, while still responding appropriately to high risk families and children. Part of the reason this topic is so complex is abuse is not just the domain of one agency. There are a range of agencies that all have really important roles in responding to a disclosure of abuse, and their role can really vary depending on the type and severity of the abuse. The common challenge is that all these different groups have the best interests of children in mind, but they bring different perspectives and priorities to cases that can sometimes result in miscommunications or conflict. The ultimate aspiration is really for a more integrated response to abuse, one where the different groups communicate and make decisions in a cohesive way, while also respecting the different statutory requirements and roles. The assumption is that you can get better outcomes for everyone and a better holistic response from the perspective of children and families with a well-planned and well-implemented multi-agency response. And what this should look like has really been the main focus of my research. While my sense is that this multidisciplinary holistic focus should really include all forms of abuse and neglect, most of my work has been on sexual abuse just because collaboration is much more well developed around this category of abuse in Australia. And similarly, some of the language is a bit more criminogenic as a result. So looking internationally at multi-agency responses, for the United States, Canada, and Europe, getting a good quality holistic response means a formalized structure for multi-agency collaboration. So these might be called a Children's Advocacy Centre or a Barnahus, which just means Children's House, each of which comes with a set of standards for accreditation and the resources to support the collaboration between agencies. There's over 900 child advocacy centres in the United States, so there's a lot of variation in how these are implemented in different areas and with different levels of resources and partner agencies. As part of a previous project, we undertook a national survey of American CAC directors to get a better understanding of the features and resources that each of these centres had. While for the most part, these are really presented as giant buildings full of agencies and therapy services and resources, like the one pictured, which is the National Children's Advocacy Center in Huntsville, Alabama, our survey directors really found that the core functioning of these centres is mostly in their arrangements for forensic interviewing in particular, which in the US context is primarily done by the NGO sector under the supervision and with opportunities for feedback from those different statutory agencies, as well as the case review meetings. So the opportunity to get around a boardroom, discuss cases from different aspects of different agencies. So those are the core functioning of those centres. What they really differed on was their levels of co-location, so the degree to which those different agencies were on site and the degree to which they have in-house services. So whether they have those therapy services and support services as part of their in-house team, or whether they rely on referral to the rest of the system within their local area. So Barnahus in Europe, they have quite similar standards, but the main difference is that most Barnahus are government-led rather than NGO-led. So Barnahus are much more similar to the type of multi-agency models we have in Australia. So to get a better understanding of multi-agency responses in Australia, in 2016, we undertook a national review of systems responding to abuse and neglect with help from the New South Wales Ombudsman, who really helped us to open the doors of the government agencies and get a clearer understanding of how they work together, particularly with NGOs. So sometimes at international conferences, I get asked why Australia has not been a big adopter of child advocacy centres and Barnahus. And I guess I'd say while our systems are by no means perfect, I think baseline practice in Australia looks a lot different to the point in time when the US were rolling out CACs. So there are specialised police in all Australian jurisdictions and specialised child interviewers carrying out evidence-based interviewing protocols, and there is a basic framework of interagency collaboration in all states and territories. So the relative benefit and need for children's advocacy centres is a little bit different for us. We sort of have different issues that you would maybe want to design around. So we benchmarked practice across the country and really identified some of the existing multi-agency schemes that existed at that time. And again, it has been some time, so I've tried to update these as best I can, but practice changes very quickly in this field. So the most distinctive differences between jurisdictions were really in how responses integrated therapeutic services into the response. So the types of services that children and family accessed following a disclosure. So we noted that lots of jurisdictions made referral to therapy services. So the top two services there, MIST, which is a pilot in WA, and the multidisciplinary centres in Victoria. Therapy is a part of the response. It's sort of integrated into, I guess, the the way that that operates. There isn't a gap between the response and services. Although it's worth noting that in New South Wales, a health worker is part of the response and they have a role in engaging the client to the local New South Wales health services. Queensland has a police referral system that prompts services to contact families. And in WA, some children will receive services from WA Health, which is part of the joint agency response here. So generally, the really joined up responses that integrated therapeutic services, they tended to be pilots and tended to draw on the not-for-profit sector to deliver therapeutic services. New South Wales is quite distinct in terms of having a distributed statewide multi-agency system that also had direct referral to a government counselling service across the state. So, really important question is, what are the effects of doing a more joined up response, and how much evidence is there that doing things in this way improves outcomes? So, as part of the project to evaluate a new response in WA, we undertook two systematic searches of the literature to better understand the types of outcomes we should be looking at, considering the different contexts we were implementing it into. So, the evidence here primarily includes child advocacy centres, but also other initiatives to create joint teams, primarily framed around the police and child protection response to abuse. So, in the research literature, the rationale to integrate responses is usually linked to attempting to improve the rate of prosecution of offenders, reduce re-victimisation, or address harms to children, or some combination of those three. And I guess we found, despite the current focus on child and family wellbeing in the field, the evidence was primarily about the criminal justice benefits of integrated approach. There was very little research on children and child and family outcomes, particularly over the longer term. And there was some evidence that non-offending caregivers were more satisfied with a multidisciplinary response. We did find evidence that integrated approaches increase referral and receipt of services for the target group. But an important observation was that the conditions being compared in these evaluations, and I think there was about 50, 58, 59 of them, were quite different from most Australian jurisdictions. So it sort of challenged the idea that you can just implement these in Australia and get the kinds of improvements, particularly in terms of the criminal justice outcomes seen in the literature. So, if part of that project, we're able to evaluate a multi-agency response as it was being implemented as part of a pilot in Western Australia and compare it side by side to usual practice at the time. Um, so, while the intervention had been implemented, I guess with the CAC model in mind, many aspects of the CAC response already existed in the existing system, as I sort of hinted at before. So we really focused on what were the key differences between this new intervention and existing practice at the time. So from a qualitative study, we identified that practice as usual had different allocation processes that generally separated out case assessment, interviewing, and intervention investigation. Different workers did each of these tasks and handed the case on to the next, whereas MIST had all of these workers involved in the handling of the case from the point of allocation, and those workers were all co-located together. So they had much more access to each other. MIST had a specialised role called a child and family advocate involved in the case from the point of interview. So this worker provided support to families during the interview and typically had an ongoing role in case updates and referral to the in-house therapeutic service and other internal and external services in the area. So in the regular condition, families were more or less provided with a list of services unless they had ongoing child protection involvement at that time. And the other difference was MIST worked within a bounded local area. So children were coming to that area to participate in a forensic interview. Whereas other cases were across the Perth metro area and really were handled out of the Perth offices. So the evaluation found that MIST enabled a more rapid response, particularly in terms of the criminal justice process, so that I guess handling of all those steps in the case by one person really sped up the process. Partly also that co-location seemed to lead to efficiencies, and that those joint working arrangements, they were able to respond to a much higher volume of cases relative to their FTE. And from our interviews, staff perceived the approach to be an improvement on existing practice. There was also a high level of satisfaction from caregivers, but there was no significant differences in terms of rates of arrest. Now, the message police really took from the evaluation was that they could operate in a more victim sensitive manner, improve their efficiency without affecting the criminal justice process for better or worse. An important finding was also that there was quite a large take up of services, particularly therapy from the in-house psychology team, and demand for other types of support services when families were supported to access them by the child and family advocate. So the observation of the difference this advocate made in improving the accessibility of these services has really framed my current focus around therapy and service access as being the most important difference a multidisciplinary response can make in the response to abuse. So particularly for Australia, like while there's space for improvement in all how these things are done, and better catering for specific target groups that may have some additional needs, mapped against the evidence, it seems unlikely that changes at the point of response to disclosures are likely to make huge difference to criminal justice and child protection outcomes. Partly, baseline practices almost everywhere already involve a degree of interagency collaboration. There's already interviewing by trained and qualified people that are delivering evidence-based protocols. And most jurisdictions have processes in place to interview children in a child-friendly environment to some degree. And again, all these elements can be improved, but uh, based on I guess what we've observed so far, it doesn't seem that there's going to be easy gains in terms of improving criminal justice and child protection outcomes. So our study in WA found that the rate of person of interest interviews and arrests did not change despite implementing a multi-agency response, and similar findings have been made in the US, specifically when comparing interagency schemes to multi-agency teams. But from a review of the theory of change for multi-agency responses, the most important areas where integrated and more holistic responses can make real inroads are in improving the accessibility of therapy and providing family support and other services that address the risk of abuse and neglect in families. And these are also the parts of the response that appear least connected to the investigative response in Australian jurisdictions, as most are really framed around that more immediate decision making about the case. So turning to service accessibility, as I mentioned from the Australian Child Maltreatment study findings, families where abuse are detected overwhelmingly tend to have a lot of things going on that will make it difficult for them to commit to engaging with services like therapy. The first one, of course, to mention is disclosure. So it's important to note that just based on the difference between the incidents reported to police and child protection and what we know from victimisation surveys, a large proportion of abuse is just not going to be reported and won't result in a referral to therapy. Second sort of category of factors is really about the complexity of the service system and just the different eligibility criteria, referral pathways, wait lists, different organizations with different names. So just the complexity of seeking and obtaining a service, and particularly one that might be culturally appropriate as well. And of course, the complexity within families and often the poor match between how systems to provide therapy are set up and the characteristics of the children and families using them. I think when talking to most jurisdictions, I think there's an acknowledgement that yes, it's very challenging, but most of the kids, make it into the system. Most of them are getting services, and it sort of looks like this diagram, and the circle of benefit looks pretty good there. But I think it obscures a pretty clear reality, which is when you consider the broader context, things look a bit more like this. So not to be a total pessimist, but I think this diagram is a bit more realistic about all the things that have to go right for children to benefit from services. And it serves as a stark reminder that our efforts in working to address the impacts of trauma from abuse and neglect in the community can only reach so far. Services are often only engaging in a very small population and proportion of the total population, and ultimately only a small proportion will make it all the way through and even have the chance to benefit from services. And it's clear that given the degree of need, we need more sophisticated approaches to addressing the barriers to access. So the start of this work is to build a better understanding from the literature on what are the typical range of rates and what are the main factors that are known to influence engagement and completion following a disclosure. So to get answers to these questions, I undertook a rapid evidence review targeting any study with information about rates of engagement and completion or how different factors affected engagement and completion. So comparable mates or rates were combined through a proportional meta-analysis. So when I'm talking about pooled rates for different groupings, this just means the rate adjusted for the different sample sizes. So factors were identified through a review of eligible papers, coding them as to whether they had a significant effect in terms of engagement and completion. So this diagram here is really the summary of the entire series of meta-analyses on typical rates for each stage. And I guess the thing to bear in mind is these are the proportion that, in these different situations get through to the next stage. So once you get down to the bottom, you're looking at quite a small proportion. And I'll get into that soon. So in terms of the likelihood of getting a referral, we found two kind of categories of studies. One was really suspected abuse, so children at that much earlier stage, which were much less likely to be referred at 47%, and substantiated abuse, so children further into the child protection and investigation process, so they were 78% likely to be referred. In terms of engagement with therapy, so the actual commencement of a therapeutic program, the sample types were broken into three groupings. So the first one, self and professional referral, these were more naturalistic studies. So they were sort of following up entire cohorts. So maybe everyone that's disclosed within a 2-year period to a particular police jurisdiction, how many of them access the therapy service within that jurisdiction. So the pooled rate there is 30%. So that's quite low, but just bearing in mind that though that group didn't necessarily get referrals as well. So the next grouping was specified professional referral. So this just means when a child protection or police made a specific referral for a child or family, whether that specific referral was taken up and they actually commenced. So for those, it's about 61%, and they had reasonably tight confidence intervals that just meant that the rate didn't vary as much across the different studies were included. So you have a bit more confidence around that rate. And the other group we sort of identified was the therapy initiators. So these are where children and family initiated contact with the specialist services. And unsurprisingly, they had quite a high rate of engagement, 81%, but with a wider confidence interval. So I guess it was reflecting quite a few different types of contexts and referral processes. In terms of completion, these studies were just split into clinical samples. So these were studies where therapy program was really strictly controlled in terms of selection and exclusion criteria, and the program was quite strict. So those types of studies had a pool rate of 73%, whereas the community samples, which were studies that really just took data from community-based clinics, didn't have quite as strict selection criteria. This group had a pooled completion rate of 59%. So again, each stage in the process towards completing therapy, we potentially lose children in the process. And look, they may need more time, they may come back, but just as likely they go out into the community and aren't picked up again until their symptoms have manifested, and usually present to CAMS or other mental health services with quite more acute symptoms. The question for systems and professionals is really what's okay in terms of attrition, and what can we be doing to maximize the possibility of children getting a benefit from these services? So these rates really reflect some indicative benchmarks for service systems. And again, depending on the type of sample, it means that for every 100 kids disclosing, you might reasonably expect anywhere from 8 to 37 to even get to the point of completing their service and having the chance to benefit from their service. In terms of factors that seem to influence engagement and completion, across the studies that were included, the most consistent findings were really that higher severity and frequency of abuse was associated with engagement, potentially because the abuse was being taken more seriously as a result. Ethnicity in a US context was consistently a factor, with white children and families more likely to engage, and parental attitudes about their children and the extent of their supportiveness in relation to abuse was also consistently found to influence engagement. In terms of completion, parental involvement in therapy was consistently found to affect completion, which was measured in a variety of ways. But more severe and more frequent abuse, increased symptomatology at intake were associated with higher completion, along with if the perpetrator was a parent or parental figure, possibly due to the greater likelihood of child protection involvement. So these really represent the broad trends across studies, which of course are limited by the factors and constructs that they happen to include in these studies. To really build on this and expand the field, my vision is more to be able to work on this in a much more detailed way within a single jurisdiction. So I recognize that each jurisdiction is likely to have different issues, and there needs to be a systematic process of identifying problems and developing and testing solutions. And research can tell us more about the common problems that exist and potential solutions. So my aspiration for this work is really to move into data-driven reform as a long-term project, partnering practice and research, which looks a bit like this screen here. So drawing from the data sources on the left, we monitor who is and who isn't getting to services, drawing particularly on our understanding of the population, the lived experience of accessing services, and the experiences of cultural safety and the inclusivity of services to better understand discrete barriers to accessing therapy. And use these sources to develop changes to processes or new interventions that are then monitored and tested using the baseline data collection. And I have an example of this as part of the presentation that I think is a great model. So in Chicago, they were able to track engagement and completion over a really long period of time. They developed a network of services linked to their child advocacy center. So they had the point at which disclosures occurred, and they had a network across the all the services in the city. So their primary issues were around huge wait lists for services and significant dropouts from services. So they I guess, looked at the range of factors that they had access to on who was getting to and who was not getting to services, and started to develop interventions to try and address that. And we're able to track in real time the improvement in terms of the engagement and completion rates. So as an example, their analysis sort of identified a lot of service level barriers in terms of transport, location, times, um, stigma in terms of accessing these services. So part of their process was rethinking about the intake and waitlist process. So they developed a centralized waitlist with a standardized intake assessment and triage. So rather than having 30 different lists, they had one list that uh, the waitlist also considered, I guess, the severity of symptoms as well as the motivation to engage. The feature I really liked was once you get to the top of this centralized list, you can go try out as many services as you want until you develop that therapeutic alliance with the person you want to work with over the longer term, which seemed like a really nice feature. Part of that initiative, they also standardized treatment and some of the language around how treatment was described across mental health providers in Chicago. People felt confused in terms of what services were called, so they standardized some of the language to help address that. And they installed quite a bit of active waitlist management. So what that means is they trade their advocates in motivational interviewing and put together some hope and healing groups. So group sort of support services. So the idea is that while you're on the wait list, you're receiving a sort of basic service that's going to address some of your more immediate problems and build your motivation to engage with mental health services. So they've been able to track in real time from the implementation of these things, improvements in wait times for services and reduced disengagement from therapy. Now, the point I took from this was not necessarily to follow the interventions that they did, but to follow the process of developing interventions matched to the data, and of course, drawing on lived experience and those people to sort of test the feasibility and to bring them into the process of solving the problems that you're identifying. So I've covered a lot of ground here, so I wanted to highlight some key learnings and next directions for the work. So while we have plenty of multi-agency responses in Australia, a lot of them are really limited to just the investigative process. But the real value of multi-agency responses in organising a holistic response is in organizing a holistic response to address the needs of children and families. So bringing in specialized services able to work with this target group would be incredibly valuable, particularly in addressing safety concerns that don't necessarily meet the threshold for a statutory response. There's a really clear need for information about the functioning of the systems that provide access to therapy services. For instance, in WA, outside of the two pilots, there's 14 different CSATs, so child sexual abuse therapy services and Indigenous healing sites. There's no single source of information from the point of disclosure of the number of children that are referred, engage with, complete, or benefit from these services in the way that I sort of was able to describe rates from the meta-analysis project. So we don't really know much about how long it takes to access these services and the characteristics of who is and who isn't accessing these services, which are really essential pieces of information for improving the service system. And finally, timely access is incredibly important. As mentioned before, re-victimisation rates are high, and this reflects both the persistence of the underlying factors in families, along with the mental health, I guess, sequence of the impacts of abuse. So not everyone's going to be in a position to commit to therapeutic and family interventions. Making these more accessible would make a substantive difference to limiting the individual and community level impacts of abuse. So as I mentioned, there's a lot of references, and if anyone is interested or doesn't have access to journals, very happy to pass these on. And I've actually made quite a thing of trying to ensure that we have open access versions of just about everything we do. Um, all right. Thanks so much for your time.
Great. Thank you so much, James. That was magnificent. And you've really, presented quite a sobering picture in a way, of just that, there's potential out there, for people being helped, but it really does put our collaborative skills to the test, and there's a lot of barriers to overcome. So thanks for such a comprehensive look at that, all based on high quality evidence and your research experience, I can see. So I know there was quite a bit to take in, and people might still be thinking of questions, but we do have about 15 minutes. If anyone does have a question for James, please raise your hand and put yourself off mute. It'd be great to hear from you directly. If you cannot speak for some reason, you can use the chat function as well. Have any questions?
Yeah, I've got a question. I'm just thinking about if you had a system that could sort of collect the data on service access, like you mentioned, what do you think the main barriers would be to accessing therapy, and if you could see it?
Yeah, I think as I mentioned from the reviews, we're mainly looking at really concrete factors, so demographic factors, things to do with the offence and things like that. It'd be great to be able to capture, I guess, things that are more psychological constructs like attitudes about therapy, um, yeah, those sorts of things. So I think partly what we might observe is one, I guess and just based on ACMS and other things like that, just I guess the complexity of some of the families that are coming in contact with this system. So just the layers of contact with FDV services, homelessness, all these things that are make life really difficult and make it really difficult to, I guess, commit to programs of therapy. I think some of the things around, I guess, the stigma of accessing services is something that I think would be uh, interesting to learn more about that being a barrier to accessing services. Um, the other thing I've been thinking about, and one of the findings from the ACMS that really clicked for me, was just the volume of abuse in the community that is HSB, like it's done by another child or another young person, and particularly, I guess, the complexity of intra-family HSB, how that's being managed, and the challenges on therapeutic services in managing those things. So I think probably what I imagine is we will get a better idea of the scale of complexity of the people that are presenting these services, and yeah, just the need for a really comprehensive wraparound of just the range of services that they need. And I think having that understanding of their needs um, comprehensively, it sort of starts to say, hey, at a minimum, when you're operating these services, you need to have clear connections to this, and this. I think that will maybe help to highlight the types of services that are needed alongside the therapeutic response.
Mariana, you have a question?
Thank you so much, James. You've really taken us on this very wide journey across this field. But you did mention something about the one-stop shop, and this is an approach that I think you said was in the US and in Europe as well. I'm curious why we don't have that here. Could you share with us a little bit on that?
Yeah, and look, so children's advocacy centres, and there's a whole fable about how they were invented, and that's why the national centre is in Huntsville, Alabama, because it was a prosecutor there that was spoken to by a mother about their experience of having to repeatedly disclose and being subjected to inappropriate interviewing and that sort of thing. Where that came from was a particular moment in time where processes were really, really bad, and the the complexity of their system. So, just as an indicator, so the United States, I think, has 18,000 law enforcement bodies, and we have what, like 7 or 8. So part of their collaborative response was to bring in all those different law enforcement agencies and sort of round them all up. And you've got your different prosecutors and things like that as well as part of that thing. The other part of it was lots of abuse was occurring in jurisdictions where they didn't have specialized police. They didn't have people that were individually trained to interview children. They didn't have procedures for that. So their designing and their building of their model was really framed around, I guess, the needs of the criminal justice system and to reduce the distress and confusion of that approach. Europe, and they've since moved on to much more of a focus on, I guess, the children and family outcomes and the connection to the sort of supportive services. I guess we differ in that we have some elements of these centres, and it's interesting. When we've had visits from people from CICs and they come to some of our things, that are not called CICs, they would say, "Oh, this is probably 4 of 10. Would pass these standards. Like there's the 10 accreditation standards." Um, so I guess the answer is because we have different challenges, which are primarily, as I've sort of articulated, around the connection to therapeutic and supportive services. We're sort of sitting in a space where, um, while there's definitely elements we can improve in terms of our criminal justice response to children, um, they already have interagency responses. They already have, you know, basic information exchange. They already have specialized interviewers that are trained to interview children. We already have some of those components. So I think the brand or the idea, rolling it out wholesale, doesn't have the same impact here, partly because we just have different problems. And I think we need to, if we want to make multi-agency responses work, they need to be formulated around the problems that we have, which I would say for Australian jurisdictions are primarily that connection to family support services, addressing that, and therapeutic services.
Thanks for that. Does anybody have any further comments or questions?
Yeah, I had a question. Thanks, James, for your presentation. It was really insightful. I was wondering if there's a change in the way different professionals interact with each other in terms of these joined up approaches. So that might be important for how children and families experience the service.
Yeah, absolutely. I actually got the chance to, so when I was doing the postdoc, I actually was based within the service that was doing this. And so yeah, I got the opportunity to sit in the building as sort of the embedded evaluator, and yeah, just, you know, have lunch with and interact with everyone that was being introduced and you know, put together on a functioning team for the first time. And you know, it was pretty interesting stuff. There was definitely, you know, if I was more anthropologically or sociologically minded, there definitely would have been like an experiential study in being the embedded evaluator there. So yeah, just that, and it's interesting in terms of that reflecting outcomes, because I always saw that as sort of a soft benefit of that co-location and that group work, in that these guys often had maybe not the best understanding of what other people in the system did or how they worked. And what happened very quickly, I think, was a greater degree of trust and understanding of other people's roles and more practical problem solving. And I think that's maybe a sort of soft benefit of some of these interagency responses, is by understanding I guess, the resources and limitations of some of these other disciplines that they're working with better, they were able to do more practical problem solving and fix issues by, you know, working together as an integrated team. And yeah, I guess the ones that I sat in, it's funny, yeah, like there was observations that, you know, people took on the language of some of their interagency colleagues, and I think there was often a bit of jostling as to like what was the sort of dominant culture. Is this a social work intervention? Is this a police intervention? That sort of thing. But I think ultimately, as it played out, it sort of created its own culture where it incorporated a bit of social work, it incorporated a bit of policing, and everyone sort of found their happy medium in that.
Oh, what an
Right.
interesting study. I would have loved to have been a fly on the wall as well. And I get, you know, I was just thinking across lots of different social issues. I love the framework that you've brought today to kind of show that, you know, we all try and put the patient first, the person first, the client first. But actually, because of our systems and disciplines, there's a lot in the way of that, as important as it is. And I guess this work has really shown, you know, the path towards that, and hopefully with research and evaluation, we're getting better at it too. So I've put your email in the chat. Thanks for your generosity of being able to share the research papers. If anyone wants to explore further, read further, ask James any questions directly. Thank you for everyone for attending today. Thank you, James, especially. And we look forward to seeing you at the next seminar. Round of applause.